we're not quite running AHW time, but we'll get started because it looks like we've got a pretty full house. Thank you for coming. This is the first SAMAC event for a while. Like everything else, we've been affected by COVID and that sort of stopped the conversations. This is the first in a series of seminar style events that we're going to be running. We are also recording them, so anyone who tells you how sad they are to have missed it, you can tell them that this will be recorded and available on Bruce in the next few days. There's another seminar in this series in November, which will be advertised. So today's talk arose from a conversation that was had in the Statistical Leadership Committee, where some of the group heads have decided that there are some conversations or some topics they'd really like to talk on. So today's topic is, and I'm paraphrasing here, how the health system works. I think my summary is with lots of money, I think is probably accurate. And Adrian will be presenting this. I'm going to shoot off due to number restrictions in this room. But Michael is here if you have any questions about the rest of the series. So without further ado, I'll hand over to Adrian.
Thanks, David. So yeah, a bit of a different one, I think, today from the normal SAMAC conversation. The origins of it are a little bit in the context of this year. We've seen some of the big questions get re-asked, I suppose, about the nature of our system, why we have the public-private split we do, what actually the purpose of our health system is in the context of pandemics and things like that, which when you go back 100 years was a really big influencer of how we ended up with the system that we have today. So I thought, and in the context of the statistical leadership discussions, we thought it'd be worth just going back to basics a little bit and talking about not so much necessarily how the system works, but how it's evolved over time to be what it is and where probably some of the causes of why it doesn't work as well as we'd hope might be. I am very much experimenting with technology here. So I have a complicated animation-y thing that I'm going to do as we progress. I had pre-recorded this and I've given this same talk over at UC recently to the public health school there, and while I used a pre-recorded version for that one, it did have the sound of turtle tank filter and dogs barking in the background and all those things that we've become familiar with in the COVID context a little bit more than we would otherwise. Before I launch into it though, I'll just pause, I suppose, to get a bit of a sense of the room, of whether there's any issues that you'd want me to cover or questions that you'd have. I will roll through this. I'm going to break the habit of a lifetime and read from a script. For those of you who know me well, know that I am not a good script reader. I tend to go off on my own tangents, but I will try and stick to this a little bit for the sake of the recording today. So I'll progress through only a couple of minutes of the animation-y bit, and then there'll be a bit of a moment to stop and pause and ask questions and talk. So let's start, shall we? Meet Joe. Joe is our every person. Around the time of the Industrial Revolution, Joe had a large family and did a dangerous job. He looks happy, doesn't he? But if you look close behind those eyes, you will see fear. Joe is constantly worried that he or one of his family will be struck down by illness or get injured. This is Maria. Maria understands Joe's fears. Maria has studied the best wisdom of the times to try and help out people like Joe. So they strike a bargain. Joe shares a little of his income with Maria in the hope he'll receive some form of health benefit or at least a bit of relief from his fears. Maria uses some of this income to support her own family, as well as invests some into advancing her skills and the health profession more broadly. Over time, as Joe's income started to grow, so did his willingness to invest in healthcare. Gradually, Maria's potential to offer meaningful help also improved, particularly with some big wins on the public health front and a range of wartime advances. But it doesn't stop there This is just really the beginning of how our health system started. In the spirit of industrialisation of the times, the Marias of the world started to group together in organisations and institutions. As a result, these health interactions started to become a bit more complex, becoming more about dealing with a professional or a professional group and possibly a large organisation, whether it be a big GP practice, hospital, or any of those other big institutions we've become familiar with. With institutionalisation, Joe hopefully gets more reliable access to certified quality health professionals and technologies, and pharmaceuticals being important here, but not necessarily a reduction in cost. There are additional costs associated with the institution, as well as extra costs for new medicines, treatments, and technologies. But that's okay. Joe is doing fairly well for himself by this point. From Maria's side, working as part of an institution or a business means she gets a range of protections, like more reliable and larger incomes, and the organisations start to see profits, gain workers, and build influence. There are transactions occurring at every point in this. And behind the evolution of our health system was the broader economy and employers. Employers wanted workers that were willing to do the dangerous jobs that were profitable and that could be repaired if they got hurt, particularly as roles became more specialised and labour replacement costs increased. Our mate Joe, in terms of these transactions, started to get increased wages from economic growth, and so did the Marias and the health business owners, because there's a relationship there between the health business owners and the economy. As a result, we see health start to become a driver of economic growth, both directly through its contribution as part of overall economic activity and indirectly through some improvements in well-being. Once again, largely as a result of some of the big public health initiatives such as vaccines. Despite this though, Joe is still afraid. Still afraid of falling sick unexpectedly and getting injured. Those fears have far from gone away. Regardless of how much more Joe earns or how much his health improves, with increased wealth comes increased spending on health. What happens when wealth stops increasing? The truth is we don't really know, as up until recently, economies like ours have tended to grow, but things have started to change. But before we go, let's go back a step. With persistent fear, workers demanding protection from employers, and health costs starting to become too high to absorb from regular incomes, insurance systems start to grow both for individuals and employers in the forms of private health insurers and workers' compensation insurance. It's starting to grow, isn't it? With both individuals and employers starting to feel the burden of costs, but also valuing the health system, it is unsurprising that health has been an important matter for governments. In particular, governments have played a number of key roles, including redressing structural biases. The system we've talked about was very biased, in all the usual ways, with those with jobs and money benefiting more. Governments intervene in the health system through a multitude of different arrangements, from direct purchasing to subsidies to tax incentives and so on. In return, what does the government get out of all this? Well, from Joe, the government gets income tax, of course, and most importantly, votes. What drives the government is votes. From the economy, the government wants taxes and once again votes. And from the Commonwealth government, the employers and the broader economy want support and assistance in maintaining that insurance cover. Insurance here being a little bit broader than the usual concept that we would use. Arguably, what happens here is in fact a transfer of responsibility into the government of what was previously, and in many economies throughout the world still is, borne mostly by employers. There is also a transaction here between the Commonwealth government and the insurance industries we talked about. We start to see Joe receive some benefits through reduced premiums. That is all very recent, really in the Australian context, but is part of systems all over the world. Once again, health insurance is part of the economy from which the government receives business taxes and votes to be gained through the Commonwealth supporting the health insurance sector. Now, from Maria's perspective, she also receives a range of tax incentives, direct practice incentives, grants for research, grants for activities from the Commonwealth government. Some of the payments go directly to the healthcare provider, some to the organisation, and once again the transaction here relates to votes as well as taxes. But there is also regulatory burden borne by those who are working within the health system that they have to bear, and that comes in the form of needing to register to be a practitioner, submitting to all sorts of forms of surveillance, of which we are a part at the Institute, and other arrangements. We have more than one layer of government, of course, in Australia, and the state and territory governments play a big part as well. Constitutionally, they are responsible for hospitals. The Commonwealth Government is essentially responsible for everything else. One important catch to this is that the Commonwealth Government has the majority of tax and revenue raising capability, far exceeding the state and territory governments. So that becomes an imbalance within the system. When it comes to the transactions relating to the state and territory governments, from our mate Joe, once again, there's taxes, there's fees. GST is really important, but a topic for another day, and votes. In return, Joe wants, once again, assistance with his fears, help with services, and improved health amenities. Particularly with hospitals, but also for a range of other health institutions, the state and territory governments provide financial support through grants as well as regulatory arrangements similar to the Commonwealth Government in return for taxes, fees and votes. That imbalance we talked about in revenue raising capability is then key for introducing the federal financial relationships we see today, where the Commonwealth Government provides money to the state and territory governments to support the hospital system, among other things, and in return there are votes and political support. So this is hopefully starting to illustrate a little bit of the complexity of the economic transactions, the benefits and social interactions that occur within the health system, and what is really a very big political economy. There are enormous tensions, of course, competitive tensions between professions and trust issues, as well as information asymmetry, for those who know that term, that abound throughout the sector. In part, as a response to those tensions and issues over time, we've seen a very complex set of regulatory policy, legal institutions and arrangements put in place by both the Commonwealth and state and territory governments that at times overlap and compete with each other. So this is it in a nutshell, an extraordinarily simplistic overview of how the health system functions, sort of. So it's as clear as that. And that really is only scratching the surface. So that was the little script I had in terms of reading through some of the evolutionary bits. Key for the Institute's perspective in all of this, of course, is that for every transaction, there's often a little bit more than just money and service that's transacted. There's also a transaction of data and information. And that's core to all of our work. It's our base administrative systems, and we've become very familiar with them. But I thought worth just sort of giving you a sense of that broader context into which all of those data systems fit, because it starts to expose, I hope as well in this, why we have some of the frustrations that we do with the data. Because for most cases, the data systems that we have and use were not designed to monitor the health of a population or to be a health surveillance system of any form other than in the context of the transactions of payments for services. There are big exceptions to that, of course, that have been developed around it, and it's interesting to speculate about what the underlying kind of motivations behind that are, at least in part, if not wholly, when you think about something like the National Health Survey and some of the other big surveys that are done really from a population health perspective. They're funded largely by Commonwealth governments, although by state and territory governments, with the motivation of understanding whether they're getting bang for their buck, whether things are getting better or worse through the investments they're making. So there's still a transaction element to this. Pains me to say it, I'm a sociologist by training, but the economics are key in all of the health system. I'll pause there, I suppose, to answer any questions or to be shouted down because I've missed something really important or got something very wrong. in all of this. Any questions or thoughts people would like to share? I did scream through it at a rapid pace. Yeah.
Forgive my stupidity as I'm not a data person. In a system like I have in the UK, which is nationalised,
Yep.
isn't it? Is it easier to collect data in that sort of system, or does that come with its own issues compared to our system?
It certainly is easier, and they've been more successful at gaining data across the health system. One reason it's made easier is because you theoretically have a single funder of both primary healthcare and hospital. Another really important reason, and this is actually part of my PhD research, was some of the cultural underpinnings of how that system works. So I did some work comparing the use of performance indicators as tools of control between context in Australia for a number of essential services, where there was a real policy and ideological underpinning of separation of government from provider and neoliberalism, for those who know these terms, and compared that with what was going on in Scotland, where there were similar policies, but not the same business-like cultural ethos that I saw in Australia. So the whole idea of hospitals working like businesses was taken up far more aggressively in Australia than it was really in Scotland. So the use of the data was very different. So I saw way more occasions where health ministers and policy people were sitting down with providers to go, we've got this number, what's going on? Talk to us about what's happening here. And there would be a conversation about what's happening. Whereas in Australia, the conversation was more about why aren't you delivering? And then the defensiveness and the justifications and all that sort of stuff that happens. So there are a number of reasons why I think the nationalised health system has better data, and some of them are not because it's a nationalised health system, because there are non-national health systems that have really good data collections as well. That's the sociologist in me, I suppose, but culture is key. Culture determines everything else, and the systems are a product of the culture, as well as they feed the culture. Yeah.
I just wonder, with the private health insurance and Commonwealth government boroughs, if
Yep.
might there be something in there as well about Commonwealth government avoiding cost?
That's a really interesting question, because that's a very topical one about whether or not the Commonwealth government does avoid costs through subsidising private health insurance. You look to examples in the education space where people argue, in fact, it costs more to subsidise private care than it does to pay for public. I'm not sure that's true. It's certainly a motivator of the ideology of having a mixed system, as they call it, where we have a private sector. We're actually having active discussions at the moment with the Department of Health about whether or not we can measure this to see whether there are reduced costs to the government through services being provided in the private system compared to the public. What we do see is that the public system tends to provide different types of services. So it's not a direct comparison. The things that people go to the private system for are not the same things that they tend to get in the public system. And I was on a workshop yesterday talking about variation in healthcare, where there's a lot of fingers pointing to the possibility that a lot of what happens in the private sector may well be low value or unnecessary care. So the ideology might be there, and the idea might be there that it's to reduce the cost. In practice, we're not well able to measure whether it does or doesn't at this point. It's important too. Any other questions? And really, I was just going to, and this partly I've already touched on. So we take the same image now and can see that at every transaction level we have data, health records being created, some of which we get access to, some of which we don't, some of which are still on paper files around the place. There's also administrative collections that occur within the organisations that the healthcare workers work within. That as a data source is essentially untapped, but I think potentially really interesting. We're starting to get a little bit more involved in issues around workers' compensation insurance and work health safety, and starting to look then at some of the not necessarily health sector, although first responders is an issue, at the data that comes through on workplace injury and claims, HR. That will be interesting. Of course, the workplace accreditation data to some degree floats through to us through the Safety and Quality Commission, but there are a range of data sources there that I don't think we've looked at, which might be worth thinking about. I skipped over the financial data. We've started to look at some of that with bank data and FBOS machine information, but it's very nascent, very new in our mindset. Similarly, at the overall economy level, we've got bank data, sales data, economic information. We work closely with the ABS, national accounts versus national health accounts, those sorts of conversations, and as well the whole of society surveys, information that gets collected. Private health insurance data. I've already mentioned workers' compensation data, which is a new area. We've always used private health insurance data from the health spending perspective, but I don't think we use it much beyond that across the institute. We have started to use it for things like disease expenditure data because they're good information sources, but we have rich data really on what claims come through, what people are receiving through private health insurance, which hopefully we can build on. Tax data. I remember a fascinating conversation a couple of years ago in the context of welfare expenditure and Oz welfare, and I was putting my hand up really to say, look, the biggest area of welfare spending is tax. It's tax subsidies. That's where most of the welfare spend goes. But that was not really seen, like that was a bit of a challenge to people because it's not ordinarily what we think of as spending data. But this is a really key part of it, and if you're drawing the link between what happens in the health system and what happens in the economy and the motivators and the drivers and the underpinnings of it, it's income support, it's tax. These are critical elements to the picture, particularly in terms of what the Commonwealth Government does. And of course, there's MBS data, PBS data, all those program data sources that we're familiar with. We used to do more on the health workforce side with the Australian Health Practitioner Regulation Agency data, APRA data, that now is run by the Department of Health, but we still use the data from time to time. PIP data, practice incentives, as I say, PBS, MBS, dental, there's all sorts of data sources that we're pretty familiar with in that context, some of which that we get good access to, some we don't. We only really, in many cases, get the surface layer, a minimum data set or something, rather than all the detail. And of course, there's the wonderful world of the National Health Reform Agreement and activity-based funding, the National Health Funding Body, the administrator, so many parties in that mix that we work with quite closely on the hospital side of things to get a picture of what's going on. I think I'll probably cover this. What's not here is those big circles underpinning it, which are the regulatory systems and the legislative frameworks. I do think there's way more that we could be doing with some of the regulatory data that we don't really do much. And what we haven't been doing is monitoring what's happening in the regulatory space and the changes over time. For those who would have seen recently the reforms to the private health insurance system that came through in the most recent budget, increasing the age of dependency for people who can then sit under their parents' insurance cover from 25 to 31, I think, on the surface. It's a mind-boggling and terrifying thought that your kids could be considered dependent up until 31. It's not one I've shared with them. But an interesting change, and when you scratch behind the surface of this, I think it's a nice illustrative example once again of the complexity of all this. So our health insurance system, our private health insurance system, not our workers' compensation, but a private health insurance system is based on the concept of community rating, which is you cannot vary, as an insurer, you are not allowed to vary your insurance premium for an individual based on their risk of falling ill or what have you. The principle being that you have enough healthy people in the insured population that it compensates for the cost of caring for the less healthy people through insurance. There's a whole world of complex mess that sits underneath that in terms of how that is administered. But we've hit a real problem in Australia in terms of maintaining that system. Now, whether you think this is a system that should or should not be maintained is an issue we'll put to the side for the moment, but in terms of maintaining that community rating, it is a problem when you see young people dropping out in large numbers, as they have been, of health insurance, because clearly, in economic terms, they're not seeing value for money in the investment of maintaining insurance, private health insurance, which means you're losing your healthy population. And at the same time, we're seeing large numbers of older Australians taking up private health insurance or maintaining their private health insurance. So insurers are very, very worried and experiencing, well, they say they're experiencing the impact on their profit margins, but I did look at the APRA data the other day and I couldn't see the sign of that. The profit margins still seem to be fairly healthy. Of course, you actually need a very big profit margin as an insurer to maintain your capital stock as a security against the risk of large-scale health outbreaks and things like that. Although they tend to manage about that by encouraging the public system to look after that so they don't have to. But if I now can move into contemporary and probably more controversial landscape, in the COVID context, I don't know if you've been tracking this. I've certainly been very interested and at some levels engaged with some of the conversations around this idea that we can and should restrict activity within the private system to maintain capability to be able to support the public system should there be major outbreaks of COVID. So this happened. This was not a theoretical exercise. Quite severe restrictions were put in place on what elective surgeries could be performed, going back to March, April. And you saw many private hospitals basically they weren't allowed to close the doors, but stop activity. And so in return, they were given subsidy payments. So a bit over $1 billion was handed out to the states in order to prop up the private system to compensate for loss of activity, but also to keep them open in case they were needed. When you think about what that actually means in terms of the nature of our system, do we have two systems, or in fact do we only have one? Because really that's about a government directly intervening in the operations of a private business, and starts to, I think, raise some questions about where we go with our private system and what the role of the private system is in Australia into the future. And those big questions which I've already touched on about, well, do we get value for money? What happens in the private system? Is it actually taking stuff that would have otherwise had to have been provided in the public system and doing it at the user pays cost? One of the more interesting discussions that come up in this place is around the concept of low value care as well as out-of-pocket costs. Clearly, we have out-of-pocket costs in the private system, and in some aspects of the private system, those out-of-pocket costs are enormous for similar procedures that might be provided either by another private practitioner or in the public system at a fraction of the cost. This raises a lot of concern, and once again, in the most recent budget, there was $17 million put into a website that the government released a year or so ago, which is supposed to provide transparency of out-of-pocket charging. And having had the conversation with Brendan Murphy around it, the motivation is to draw back those people who are charging large amounts. I won't say extortionist, but I'm tempted to. But why do we care? If somebody chooses to pay an enormous out-of-pocket cost for a health service and they're able to, what does that matter for the public system? It's an interesting question that doesn't come up in the discussion. Yeah.
I used to work as a private health insurance ombudsman, and from the complaints that we received, I'd say that there's a lack of information and awareness, and some people pay because they don't think they have an alternative.
Yeah. Information asymmetry, so Matt touched on before. So that's so that's about, as an ombudsman, ACCC type issues about whether somebody, it doesn't matter what sector you're in, if you're purchasing a product and you don't know what the full cost is before you purchase, that's malpractice or whatever you want to call it. I actually have walked out on a dentist without paying in my career because I'm aware that they have to tell you what the charge is, and there was a conversation before the service was rendered that said, oh, this is what we're going to do today. You okay with that? Yep, sounds good. They went and did some other things while I was there that I didn't agree to, so I didn't pay for them. And you are within your rights to do that. But that gets really hard when you're under general anaesthetic and you have a senior consultant come in afterwards and just hand you the fee and say, this is what we needed to do. The good ones will try and explain all the rationale for why they needed to do it. Some won't. They'll just say this was necessary. Who are you to question my judgment? But it's a very tricky space. So, yes, fee transparency is a very hot issue. The government's been smacked over the head about it because even the website that they've developed doesn't actually give you patients that transparency. And it's voluntary, so the ones that charge the most are least likely. There's some really interesting research that I came across a little while ago too by the Melbourne Institute that suggested that the end outcome of fee transparency is generally an average increase in fees. Because what you see is the people who are charging above the average go, well, that's because I'm particularly good or my clients will pay or whatever the rationale is. And those that are below go, oh, I should be charging a bit more. Why would I charge below the average? And so you end up seeing an average increase. This is part of my passion of why indicators are evil, and we need to look well beyond a single number to understand and use things as tools of control. That was really all the core stuff I wanted to talk about today, but of course I love this stuff. I could talk about it for hours and hours if you've got specific questions about, some of the idiocies of the MBS or PBS or whatever particular area you're interested in. So over to the floor.
Okay, along those lines, if you could organise the health system in Australia, how would you organise it?
Revolution. Look, I actually think, despite what you might get from my some of the earlier statements, given how complex it is, given the political economy that is so complicated, our system is pretty good. When you look at, so one of the issues that's come up over the last couple of years is out-of-pocket charges for GP services, for example. And what we see there is generally it's only the wealthier people that get charged, and even then they really don't get charged that much over the course of a year. So our universal health system, although I think that is a gross overstatement, because it doesn't cover really important healthcare like dental. So universal in terms of population coverage, but not in terms of the services that it covers, is pretty good so far as it does tailor our services in a way that tries to rebalance some of the structural inequity. What I would do is hand over total control of the health system to the states. I think I'm generally a believer in the local administration of systems with centralised funding, if that makes sense. So you would, as we do with GST, for example, which I mentioned earlier, GST is a tax levied by the Commonwealth Government, but it is considered state revenue and is transferred directly to the states, and they can choose to spend it where and how they see fit. I think the role of the Commonwealth Government in health should be one of drivers of regulatory consistency and getting rid of red tape between jurisdictions, but actual service delivery, planning, decision making in the Australian context is better done at a local area. And that's, particularly an Australian problem, or it's a Canadian problem, it's a problem in other countries as well, because of the oddity of the way Australia is geographically arranged, as well as arranged by population, with everybody living in this tiny little strip. And then this other problem. Yeah. So there you go. Vote for me in the next election. And I'll devolve the system to the states. And look, it's been talked about. There was a white paper that the Rudd government worked on. It was a green paper and then a white paper for reforming the federation that looked at some of these models. I probably swim against the stream there, because most people suggest it should be nationalised rather than devolved, and that we should centralise. Now, I'm going to make some policy comments here that are not appropriate for an institute employee, but I'll make them as an adjunct professor of the University of Canberra. When you notice the difference in the way that the parts of the health sector administered by the Commonwealth have responded to the COVID pandemic, and compare them to the way the parts of the system controlled by the state and territory governments have responded, I think it's very indicative of the ideologies of how they're structured. What we've seen in aged care and in the level of attention to things like providing PPE to GPs and primary health care. The Commonwealth Government has an ideology that's been around for a long time of arm's length, separate the provider out from the government, give them the money, and pretty much just trust them to do the right thing. The state and territories obviously are far more actively involved in the running of hospitals and owning of hospitals, and more directly accountable to local populations for how individual hospitals are run, and they're way more responsive because of that. And we've seen some pretty amazing things done with hospitals. I forget the name of the hospital in Sydney, but within I think 4 weeks they created an entire virtual hospital. So by building shipping containers and putting them into car parks and setting those shipping containers up with all the technology required to do telemedicine and online consults, get people on phones, clinicians working, that they avoided people having to come in who really needed healthcare anyway. We've seen some amazing stuff done in the hospital system, and to be blunt, not a lot of great coordination of what's happening in primary care. And when you go beyond that to things like allied health, they're on their own. So I think that's another key aspect to why I'd be worried about a nationalisation of Australia's health system. I'll probably be sacked now. I think Barry on the phone.
You were talking about telehealth. I'm just going to go back to Joe.
Yep.
And Joe was using telehealth, but it was funded. Okay,
no longer, government funded. Joe's having to pay an additional fee. So the transaction has now been reduced because if Joe was Josephine as wanting antenatal care, you're not getting as good a service, but Joe's now getting charged for less service in that telehealth.
So, interesting, this came up in the workshop yesterday. The perspective that was put forward there was the opposite view, which was that before the health providers were providing telemedicine, telehealth, and not getting paid. Now they're doing it and getting paid. Now, in terms of Joe, or at least in terms of the telehealth items that have been introduced with COVID, they all have to be bulk billed. So there's no additional cost for Joe with the new telehealth items, no direct additional cost. The estimate I think that I saw yesterday was about an additional $50 million a month, maybe through the MBS as a result of the introduction of the move to support greater telehealth. So Joe's paying, but only so far as it's through tax payments and what the government pays. So
Received an email from our GP that we're going to be separately charged, not bulk billed.
So the most recent charges, I think, have removed the bulk billing protection on telehealth. So I'm not totally up to speed with exactly the detail around that, but if you're getting told that by your GP, they've clearly found a way to charge. I mean, one of the things that doesn't, there's one of the black holes in all of this, and there are many, are the administration fees that get charged, particularly by private specialists, which are utterly invisible because they don't come through the MBS data. They deny them when asked, but they can be exorbitant. Not suggesting your GP's doing that, but there are other ways that they can work out how to charge things. But yes, so will be very interesting. We are tracking what happens with those telehealth items. There's a range of restrictions and there's a lot of concern, obviously, with the telehealth that it means a reduction in service, that people not walking into a clinic means that there isn't that opportunity for people who deal with broader health problems, things that they might not raise. How does somebody smell? What do their eyes look like? What's their skin look like? These are all things that are really important markers of somebody's health that you cannot see over the phone. And that's why when you look at those, there are a range of restrictions. So one of the restrictions that I heard argued against yesterday was the one about a geographic restriction, that you can't do telehealth items, my understanding is, for people outside a certain area from your practice. The logic being you should only be doing telehealth items for patients you know well and are regular kind of clients. Although the counter argument was that people wanted to maintain contact with GPs, etc., that had moved outside their area, and they wanted to do that through telehealth. So there's always so much complexity to this. Where telehealth goes and telemedicine more broadly, it's going to be really interesting. Underpinning that is a very deep shift culturally and in terms of the education awareness that people have about health system. A lot's been said, some of it somewhat unreliably, about shifts in people scrutinising and questioning science. We've had the climate change deniers and this broader thing about anti-vaccination campaigns and the idea that we don't trust science the way we used to when we're starting to question things irrationally. I don't actually think that bears out in reality. When you look at the trend, I think we've always mistrusted people in authority at some level or another, and I think we trust science and scientists more than we ever have. But I think part of the reason for that is we've become, at least in Australia, for the privileged in Australia at least, more aware, more educated about what science is, how it works. And that leads us to question things a little bit. which is really important, but it also means that we're far more informed consumers of healthcare than we ever have been, which gives me a little bit more faith that some of those issues around telemedicine might be manageable. But I'm talking in broad generalities there, and there is a lot of distribution issues. It was the WHO said not long ago that, at least for developed economies, the greatest challenge in the health sector is one of distribution of resources, not of growth or scarcity of resources. And we see that now. We're sneak preview of data that's going to come out in a couple of weeks. You know, we're up over $190 billion in spending on health in a given year. It's $500 million a day or something ridiculous that we're spending on health. You think about that as a resource pool, it's enormous. Why aren't we all the fittest people that we could possibly be? Might end there unless, we've got a few more minutes, don't we, Michael? I don't know. I don't even know how long this is supposed to go for. 10 minutes, okay.
Adrian, I mean, we've talked a lot about, I guess, like, this is essentially based on Joe wanting someone's expertise and paying for that expertise and so on, and the government comes involved. Where does, I guess, prevention come into all of this, and the idea that rather than paying for treatment, and shouldn't we be investing in prevention, and would that save money?
Yep.
So on.
Isn't it one of the great ironies of all of this? I talked a lot about fear being the major driver of spending in the health system, and you would think the best way to mitigate your fears would be to try and protect against bad outcomes through preventative health measures and things. But because of the economics of the system, that hasn't been the response by and large. It's been more about that service interaction, how to improve that, as the system grows. So we're about, the latest data is about 1.6% of overall health spending is in the kind of public health, preventative health space. That's a gross underestimation because it doesn't include the type of preventive health activity that a GP does during a consult and that sort of work, but it is indicative of the fact that, well, it's not a big part of the picture. Where it becomes part of the picture is where really people like the Commonwealth Government go back to the point about health insurance. We've got a couple of strategies here, guys. We're really worried about spending going out through the roof. We can either push people out to the private system so we don't have to worry about them, or we can try and stop them getting sick. Unfortunately, the last one doesn't work. And every economist that's ever looked at it from a cost-benefit assessment perspective goes, it just doesn't work to prevent health outcomes. Like, preventive health is a net cost on the economy because you end up having to support people with multiple conditions for longer periods of time as they age. Because what's tended to happen, and this was some data we produced a couple of years ago, is we were hoping that what we would see over time, if you look at spending by age, is that health spending started used to start to increase in the mid-40s to 50s for people, particularly through hospitals, and then obviously really accelerates into the 80s and 90s and then drops off after you die. We were hoping that with life expectancy increases, you would see that pushed back. So the morbidity compression thesis was that you instead of 45 being the start of the upward tick, it would become 50 and 55. So people are getting longer periods of healthy life. That's not well, that might be the case in terms of healthy life. I think we've got some burden of disease data that could be used on that, but it doesn't appear to be the case in terms of health spending. So we start to spend, and this is in hospital care, still at the 45, and it goes up and then continues going for a longer period of time as life expectancy increases. So that's a bit of an illustration of how stopping people dying through improved preventive health measures actually ends up in a net cost to the overall system. But there's so much in all of that I'm skimming over. Of course, The counter argument to all of that is that some great research, it was Cooper and Thomas or something, that looked at 100 years of health evolution up to about 1970 or whatever, and determined that only about 1% of the improvement in population health was due to the health system. Everything else was because of sanitation and public health measures. Whether that's still the case in the last 50 years or so, I'm not so sure, but certainly, where we've seen the biggest gains in health have been through things like smoking cessation, seatbelts, approved vaccines, although there's not been a lot of gain for 50 years probably in the vaccine front in terms of health expectancy, life expectancy. So I mean that's a we can talk about that little issue for a long time, but hopefully when you take that starting premise, and I do believe it's a starting premise that was a key foundation of the health system. I'm not saying it was the only piece. Obviously, there was the cholera work and the public health work that happened as well that went, hey, there's something in this. We should be actually investing in public health interventions. But when you look at where the money gets spent today in our health system, it's at that interaction level, the transaction between patient and provider. Population health, preventive health measures have fallen by the wayside. And on a topical note, following the SARS-1 epidemic, there was commitment to develop vaccines for coronavirus. First couple of years, a lot of activity, we're going to do this, we're going to solve the problem because we think, well, we've known for decades that a big pandemic was coming. We've literally known this. Tension waivers, the money's not there, there's not a financial return for the vaccines that's coming through. So the reason we don't have a coronavirus vaccine today is probably because you can't build one. Coronaviruses are just particularly problematic for vaccine researchers, but also because the funding dried up and tension wavered and went elsewhere because there isn't that immediate feedback. It reminds me again of another topical story, which I'll probably end on. Earlier in the year, pre-COVID, I did a bit of a deep dive into bushfire issues and read a review of all of the inquiries that have occurred into bushfires, going back to, I think, 1936 or 38, when there was a big bushfire in that year. Probably the closest that we've seen to what we saw this year. And the conclusion I drew from reading that review was all of the reviews have largely recommended the same things. Those recommendations have all pretty well been implemented in one way or another, but attention waivers, effort moves on to other areas. The recommendations stop being implemented over time, and then we have bushfire again, which is exactly what we're seeing with pandemic, really. Thanks for listening. Hope that was interesting. I think we now need to tell Dylan to